I'm gonna kick off. So hello everyone. Today I'm just going to tell you about a case that we currently have at Red Cross. It's a 3-year-old who's from the Eastern Cape who is living with her granny in a rural area, and her problem essentially started as a pimple in September on her nose that no one really thought much of. But then this year in April, early April, she came to live in Cape Town with her mom, who brought her to a healthcare provider to review the pimple and was treated for sinusitis at that stage. And then in the second week of May this year, the lesion on her nose started to enlarge quite quickly and was associated with pain and discomfort. And this occurred over about 3 weeks. And so she represented to Red Cross. The lesion was described as indurated, nodular, erythematous, mostly affecting the right side of the nose. And there was also associated right-sided facial swelling, and the right eye also appeared to be being pushed forward. So she was seen by ENT and was assessed to be possibly a complicated nasal vestibular abscess with facial and periorbital cellulitis, and so was commenced on coamoxiclav, which was later changed to ceftriaxone and metronidazole, but she completed about 7 days of antibiotics. On the same day of her admission, she had a CT scan of her face just to help delineate the pathology of this presumed infection. And what they noted was quite a lot of periorbital tissue swelling that was also displacing the eye upwards. And also what they saw was that she had some fractures in the orbit, as well as some destruction in her maxillary sinus. And this was pretty much in keeping with what the ENT surgeons described when they went to debulk this tissue. They said that it was very vascular, very friable and healthy looking tissue. And the integrity of the floor of the maxillary sinus was also quite fragile. So at this stage, there was quite a large differential about what this soft tissue swelling and what this lesion on the nose could be. And one of them is this trauma because of that finding of orbital fractures. But interviewing the mom and subsequent Lodox scan did not suggest that. Then the consideration was, is this bacterial infection or cutaneous manifestations of TB or deep fungal infection? A tissue that was sent from that surgery was negative for bacteria and TB. We did isolate Candida albicans from 2 of the tissues, but that invasive fungal infection wasn't noted on the histology, and we didn't really think that that was too significant. Then there was also consideration of, could this be a malignancy, a rhabdomyosarcoma, or any other nasopharyngeal or skin malignancy, but radiology and histology was also not in keeping. One of the big differentials, though, was, could this be a non-infectious granulomatous disease like Wegener's granulomatosis or sarcoidosis? And histology was in keeping with this, demonstrating quite a lot of granulomatous inflammation. But then we were subsequently alerted histopathologist that they were seeing something interesting on the slides. So I'm just going to stop sharing for a second and hand over to Dr. Shivani Singh, our histopathologist, to so that she can show you what we were seeing, what she was seeing. Thanks.
Welcome, Shivani, and thanks for participating.
Thank you. Thanks for having me. Can you see my screen?
Yes, we can see
We
it.
can.
Okay, so we received multiple biopsies from this patient. One was of the skin of the nose and additional biopsies from the maxillary sinus. And the biopsy of the skin from the nose is the one that showed us was the diagnostic one. And here you can see in the first picture, a section of skin showing diffuse inflammation within the dermis. On higher power, you can see that this inflammation is composed of these granulomas that comprise aggregates of epithelioid histiocytes with peripheral lymphocytes. We had admixed Langhans type giant cells, and the adjacent dermis did show chronic inflammation composed of lymphocytes and plasma cells. in some areas, the granulomas did show central areas of karyorectic debris in keeping with necrotizing granulomatous inflammation. So, it did give us a broad differential diagnosis, and we did a lot of infective stains to exclude fungi and TB, and the PAX and ZN were both negative, including some silver stains that we did. However, in some of the sections, very focally within the center of the granulomas, we did find these organisms, and you can see within the circle here that we have this uninucleate organism that has sort of vacuolated cytoplasm and very prominent karyosome or central nucleolus. This is just in another field where we had, you can see this is granulomatous inflammation. So we've got this sort of palisading epithelioid histiocytes surrounding this organism, again with vacuolated cytoplasm and a prominent karyosome. So, so based on the morphology, we thought that this looked like free-living amoeba. So we did favor that the possible cause is a protozoa, possibly free-living amoeba. But yes, we were hoping that microbiology could confirm that.
Thanks, Shivani. Just want to find my slide. Can you see my screen again?
We can at the moment. It's not in presentation mode.
Is it not? Oh, sorry.
It's not a problem. Try. Yeah. Great. Yep.
So now, based on what Shivani had shown us, we were worried about, are we potentially dealing with a free-living amoeba infection? The histology showed very few of those organisms, so we were not really sure at the time, and it's a very uncommon infection. This was the first time I was encountering it, and this is not a unique problem to South Africa. Globally, it's a very rare condition. So we scratched our heads and we went to the literature and we consulted the experts within our network to try and confirm this diagnosis and come up with some kind of appropriate management plan for this child. Unfortunately, the tissue from the last set could not be sent because it was used for TB culture. So we needed to take repeat samples of the nose, which was then sent to the NICD for parasite culture and PCR. Importantly, we had to send the sample without any saline because free-living amoeba can contaminate saline and other additives. So we wanted to just send the sample as is. And we also had to facilitate transport timeously because obviously the fresher the sample, the better the culture results. So just to try and optimize that. One of the other things that we did do that Prof. Reen kindly did for us when we thought that this could be a free-living amoeba infection was via Prof. Bloomberg, also consult the WHO to see if we could try and access a therapeutic called multefacin, which has been coming up in the literature as a therapeutic option that seems to have better results when treating this kind of infection. So given the duration and the presentation of our child, we were thinking along the lines of, could this be an acanthamoeba or a Balamuthia mandrillaris free-living amoeba? But before I carry on with the patient's details, I thought I'd just give you some background about free-living amoeba because it's not very common and quite a lot of people don't know about it. It's a very common organism that's found in the environment throughout the world, found in soil, in water, and that includes city water supply, sewage, pretty much anywhere where there's organic material. Billions of people in the world are exposed to free-living amoeba, but they rarely cause infection, with few hundreds of cases described with CNS infection and few thousands of cases described with amoebic keratitis caused by acanthamoeba. The reason why some people get infections and others don't is not very clearly understood. And there are three main pathogens within this group that cause human disease, and that's Naegleria fowleri, Acanthamoeba species, as well as Balamuthia mandrillaris. So Acanthamoeba and Balamuthia tend to be grouped together because they have quite a lot of similarities, and Naegleria is on its own because it behaves quite differently. So when I talk about Acanthamoeba and Balamuthia, I'm often going to clump them together. But just to start off with Naegleria fowleri, that's the one that's most commonly known and has been described as the brain-eating amoeba. It's usually found in warm waters. It's thermophilic, so it usually shows up in summer, tropical areas, temperate areas, and is associated with swimming and recreational activities in water. So how its point of entry is that someone usually goes swimming, the amoeba is in the water, and then enters the nasal cavity, passes through the cribriform plate, and infects the olfactory bulb, and then causes infection in the frontal and parietal lobe commonly, because that's the proximal area where the olfactory bulb is. And then the disease that it causes is primary amoebic meningoencephalitis, and this usually happens in healthy individuals. With Acanthamoeba and Balamuthia, the cysts and the trophozoites usually enter either through the lower respiratory tract or through skin that has been breached. And then from here, it spreads hematogenously to the central nervous system, causing granulomatous amoebic encephalitis. And it can also cause skin infection, like what our patient had presented with, as well as Acanthamoeba being the causative agent of amoebic keratitis. They are different forms in which they appear. So they mostly appear in the cystic form and the trophozoite form. The cystic form is basically its mechanism of survival, where it encounters, when it has an unfavorable environment, it encysts, and these cysts are pretty hardy, very resistant to chlorine and desiccation, and that's how they survive. The trophozoite form is where they feed and divide, and this is the infective form. Naegleria has an additional form, which is the flagellate form, and that's just essentially when it encounters an unfavorable environment that then changes to this form so it can move and try and find something more suitable. So this table just describes some of the differences and common findings. So with Naegleria, as I said, it's found in warmer waters. It mostly causes disease in immunocompetent children and young adults with recreational water. Disease progression is very, very fast. It's acute, it's aggressive, with death occurring in a few days to a week if left untreated. And with Balamuthia and Acanthamoeba, it's found, Balamuthia is mostly found in soil, with Acanthamoeba being the most ubiquitous of the three found in soil, water, and cysts have even been described to be found in the air. Balamuthia can infect immunocompetent as well as immunosuppressed people, and Acanthamoeba, when it causes disseminated disease or CNS disease, it's mostly in immunosuppressed people. So Balamuthia and Acanthamoeba cause granulomatous amoebic encephalitis, and as I mentioned, it's via hematogenous spread, so it can pretty much occur anywhere in the brain, but the most common areas are the frontal, parietal, and temporal lobe. Can cause skin and sinus infection. And the course is quite variable, with some patients presenting pretty acutely with death in a few weeks, but most times it's a subacute presentation lasting weeks to months. The pathogenesis between the two is also quite different, with Balamuthia and Acanthamoeba. The pictures on the left is what I'm focusing on. The immune response here is typically a type 4 hypersensitivity reaction where previous exposure to the antigen has occurred, with macrophages and lymphocytes attempting to wall off the trophozoites and within a granuloma and secreting lytic enzymes to try and control the infection. On the right, with Naegleria, the immune response is typically an acute inflammatory response, with interleukin-1 and tumor necrosis factor being produced by neutrophils and macrophages, leading to tissue damage and necrosis and marked cerebral edema, which is usually what we would find with bacterial meningitis as an example, whereas Balamuthia seems to be more kind of a response that we would see with TB. So moving on to diagnosis, the first thing is that we need a high index of suspicion because aside from the histology, which is routinely available, most times you have to refer samples to a reference lab. And what we would be looking here on microscopy and histology for in the tissues is looking for cysts and trophozoites. Of note, Naegleria, you will only find the trophozoite form in tissue. And you can also send CSF looking for motile trophozoites, but this is mostly useful with Naegleria and not so much with acanthamoeba and Balamuthia. Parasite culture is most commonly done with non-nutrient agar with a layer of E. coli overlaying it, and then they inoculate the tissue with your potential amoeba on it looking for phagocytosis of the E. coli, and then they take a wet mount of this looking for the trophozoites, and you can see that in the picture at the bottom. This is useful for acanthamoeba and Naegleria, but not useful for Balamuthia, which requires tissue culture. Then also you can do PCR on the sample cell sent, as well as antigen detection using immunofluorescent antibody tests, like the picture in green on top, to visualize the organisms. As far as treatment goes, this slide, you can see that there are many different therapeutic options listed for free-living amoeba with different mechanisms of actions. But there is no fully effective treatment option, and treatment is usually given in combination. But which options to use and which combinations to use are poorly defined and are pretty much based on case reports with some in vitro anti-amoebic activity, as well as whether these agents penetrate the brain or not, taken into consideration. The major groups here, you can see the azoles, flucytosine, sulfur-containing antibiotics, nitroimidazoles, pentamidine, the macrolides, and rifampicin and amphotericin B. So there are a couple of recommendations available, though, despite this, and most of them are pretty similar with odd differences here and there. I'm going to be showing you two recently published recommendations, and the reason why I chose these ones is because they were the most recent ones that I could find, and I just thought with the disease with that's so rare, that's based on case reports and a couple of anti-amoebic activity studies, as well as drug penetration into the CNS, as much information as possible is probably the best way to go. So this reference is from Mendel, and you can see the variability of treatment recommendations between the different free-living amoeba. And a good example of this is amphotericin B, which is the drug of choice for Naegleria, but has very little anti-amoebic activity against Balamuthia or acanthamoeba. But what you will see is that I've highlighted miltefosine, as the recent literature is consistently suggesting that this drug, when used for treatment of free-living amoeba, seems to be giving better outcomes, although this is also based on case reports. These recommendations come from a publication this year, and what this group did here was they looked at published case reports and looked at the regimens described, and they grouped them together, and they reported on the number of patients who were treated with the regimen and the number and proportion of patients who survived using this listed combination. So I didn't want to get bogged down on the actual names, but I just wanted you to see that I've highlighted some of these agents in green, and that's the ones that I've highlighted are also the recommendations that was made by Mendel. And the idea is just to show you that there is similarities between the recommendations, and this is also consistent with the CDC recommendations. So coming back to our case, what we ended up doing was starting her on fluconazole and albendazole with the hope of getting miltefosine for potentially cutaneous free-living amoeba infection. She didn't have any neurology clinically and had a normal CT brain on admission. And the plan was to send CSF for cell count and parasite culture and PCR as part of the workup to exclude CNS disease. And the rationale for our regimen was that most successful case reports use this combination for Balamuthia. Fluconazole and albendazole were easily available. They have good CNS penetration, although they're amoeba static. And the recommendation to add miltefosine was also because case reports had described progression to CNS disease eventually if you don't add it to this regimen. And as I said, the literature is supporting this. Addition, the drug seems to be amoebicidal and has good CNS penetration, and it seems to be a well-tolerated combination. Unfortunately, though, the very next day, our patient developed neurological symptoms. She had ataxia, nystagmus, was lethargic, and had a decreasing level of consciousness with a GCS of 8. CT scan showed right frontal cerebritis and possibly early abscess formation. And so we added flucytosine, cotrimoxazole, clarithromycin to the albendazole and fluconazole. I phoned Prof. Freen to check what was happening with the cultures, and the culture was negative, and the acanthamoeba PCR was negative, but the Balamuthia PCR was positive. And so based on her clinical response, and now that we had confirmed the diagnosis, we managed to contact the WHO, who agreed to donate some miltefosine, which arrived 6 days later at our institution. And I've just highlighted the drugs here, so you can see that you know, it's a mixture. Our regimen is a mixture of what we had available, and pretty much we'd included all the classes except for pentamidine and amphotericin B, which in Balamuthia is not really effective and also comes with a lot of toxicity. So this is just a slide of the real-time PCR amplification curve for Balamuthia, and underneath the green arrow, the two curves are the patient samples, and you can see the shape of the curve is pretty good, and the CT value is between 22 and 23, indicating a good positive result for this test. Miltefosine was started on the 15th, and dosing was based on leishmaniasis treatment guidelines. We received adult capsules, and we had to dissolve it to make the appropriate pediatric dose. She had a seizure on the 15th as well, but after that remained neurologically unchanged for approximately 2 weeks with a GCS of 8, but maintaining her airway with a good cough reflex. Unfortunately, though, yesterday her GCS dropped to 5 and has since then been fluctuating between 5 and 9, and repeat neuroimaging yesterday didn't really show anything that has changed. And she's had about 5 CT scans since her time of admission and 1 MRI, where you can see the progressive changes from the left to the right. So in the beginning, they were worried about this area over here. And as time goes on, you can see that it's starting to declare itself a little bit more, with more kind of obvious lesions on the third CT scan. So the challenges that we're facing at the moment is, given her clinical presentation and where she is now, how long do we give her to show improvement? What neurological deficits is she possibly going to have? What will her quality of life be? Are we actually prolonging her suffering? Is the CT brain findings and clinical presentation as a result of disease progression, or is it a reaction to the effective medication and dying amoeba and the immune response to that, or both? How are we supposed to follow her up? Does our combination need to be altered given this lack of clinical improvement, although I'm not sure how soon we're supposed to expect clinical improvement? How do we follow her up just clinically, or should we be doing neuroimaging? She's had so much imaging already, and all of this imaging has mostly been done in response to decreasing or levels of consciousness or new neurology. What should her intervention level be? As I said, her GCS has now dropped to 5 and fluctuates, which has brought up questions like, should she be intubated and ventilated? And how do we just make that just kind of a decision? And also, if she then now gets any new findings on imaging that can that would need neurosurgery, should we actually proceed with this given the poor prognosis? So I think just in the interest of time, I'm gonna skip this slide, which is pretty much just to say we want people to be aware of this, because a rapid diagnosis and intervention is potentially life-saving. And just move on to my acknowledgements, just to thank everyone who was involved with this child. It's been quite a distressing road for everyone involved, and I would just like to hear what everyone else thinks about the case. Thank you.
Hafsah, thank you very much indeed for a really wonderful presentation of an incredibly challenging case. And I'm sure there are a number of questions, and it'd be great to get comments from some of our guests. If one can, could you please, if you are talking, and Hafsah, maybe we can see you, if you can pop your video on. Lovely, thank you. I'm going to ask John and James and Lucille in particular to comment, but I just wanted to ask two questions from my side. I mean, the first is that clearly, as you outlined, there's this difference between the aggressive sort of acute inflammatory disease from the Naegleria versus the more granulomatous, sort of not indolent, but slightly less aggressive. But why, if trophozoites of Balamuthia why can't they also get into through the olfactory bulb, do you think, and cause the same sort of acute aggressive illness as, I mean, maybe that, if you don't know, maybe that's something John could answer. And then my other question is, I may have missed it, is she on steroids? Because her brain scans look as if there's, a lot of cerebral edema, and looks very tight. But again, I would ask James to comment, because I'm not so used to looking at pediatric CTs.
No, she's not on steroids. And actually funnily enough, before Shivani alerted us to those organisms, that was the discussion, whether or not she should be on steroids for non-infectious granulomatous diseases. And she wasn't started on it, luckily.
But now she's on treatment, then there may be a role for steroids here. Maybe we can ask, I mean, James, would you first off be able to comment from the pediatric ID side?
Yeah, Mark, thanks. I mean, the question of steroids
Can we
arose
see you, James?
Oh, sorry, yeah, sure. Thanks, Mark. The question of steroids arose early on, and one of the things that came through in some of the case reports was because of delays in diagnosis, quite often these children were put on sort of prolonged topical or sometimes systemic steroids, and that seemed to actually accelerate disease. And so we were quite wary of that. But your point is well taken, that now that the child's on this broad, spectrum of antimicrobial cover, of which we don't know how effective it really is going to be, whether we should introduce steroids. But with effectively clinical progression, we thought it was clinical stability, but there's clinical progression now. Well, how can I put it? I don't know if we've got a lot to lose by adding steroids, but we also kind of at the margins of therapeutic intervention. And so I think it's an open question, but I'm happy to, like everything in this case, it's really been a multidisciplinary discussion. Lyndall Gibbs is on the line from palliative care, actually, and she might, her role has been increasing in this case, so thanks.
Thank you. Maybe I can come to Lyndall in a sec. I just wanted to ask John Freehan. John, would you like to comment perhaps on that issue of the difference again between the Naegleria and Balamuthia in the olfactory bulb, and then, but just in general, if you have any comments, would be great.
Well, certainly, acanthamoeba is known to colonize the upper respiratory tract. If you swab people's throats, you'll find a good percentage are carrying acanthamoebas in the pharynx. So I think it's possible I mean, it's not impossible that, you know, that colonization could extend to the upper nasal passages. But it's, I think the association with Naegleria is often tightly related to swimming and diving in warm water, where the Naeglerias are in the form of amoeba flagellates, and so they're actively swimming around in the water, and therefore have ready access to the olfactory epithelium, whereas Acanthamoeba and Balamuthia, aren't really swimming around in the water, so there's less association with, getting the olfactory epithelium wet. But there is some association with water exposure with Balamuthia in experience in Peru. They see quite a lot of cases there, interestingly, and there is sometimes, or maybe quite often, also an association with swimming or exposure to fresh water. So, but it generally seems to be via skin and lung rather than via the upper nasal passages.
Fascinating. John, are we missing a lot of these cases because we're not looking for it, or is it, or do you not think so?
I think we are. As far as I know, there's only ever been one Naegleria case diagnosed in the country. And, given the amount of, warmish water at various times of the year, I'm pretty sure people are exposed, but I think it just gets diagnosed as acute meningitis. And the more chronic forms will, I think, also probably get missed or dismissed as TB or other chronic encephalitis things, and no diagnosis is made, no definitive diagnosis. Yep. So I'm pretty sure there's more of it than we think.
No, thanks, John. Lyndall, would you like to comment on the palliative care side and the potential role for steroids in your view?
Yes, thank you for having me. I think we always have to look at the patients from quite a different perspective to infectious diseases, really worrying about her quality of life and if we're going to achieve a good outcome for her. I think this mom is really battling to grapple with the fact that this child walked into the hospital and is now comatose. So, we're trying to support her through that. But what we need to also understand is if we do get her out of this, if she does survive, who is she going to be? I mean, is she going to be a child with profound brain damage? This granulomatous disease seems to just be progressing as we're going along. So, I mean, if steroids, for me, if they were a last-ditch attempt to do damage control, certainly with expert input of all of you, I would give it a bash, because I feel like right now we are just biding our time until this child succumbs eventually. And I think that's the big ethical concern I have as well, is that should we be doing everything? Right now she's in a ward, she's in room air, she's not a high maintenance patient. But if we do find she's progressively deteriorating, is it judicious to her to put her back into ICU and ventilate her and give her life-sustaining therapies? And also, does it serve the justice for the other patients who, there's massive bed pressure. So we always have to think of that distributive justice of who's in that bed. So I don't know if she would be the best candidate for the last ICU bed. So my big aims in terms of clinical management is always to try to keep my patients out of ICU and optimize them. But really a lot of difficult conversations have happened around her.
Thank you. Thanks for that. And you're quite right, obviously, and there are people on the call, James and others, far better able to comment on this than I from a pediatric point of view. James and Hafsah and John, I mean, just one last thing from me. I don't see anybody's hand up, so but in TB, meningitis and tuberculomas, I hate to say this because it is very different, but it's granulomatous, and as last ditch attempts at recalcitrant lesions, we've tried thalidomide in the past after steroids. And, you know, I mean, if you're deciding to actively treat, I mean, from my point of view, I think steroids, if she's deteriorating, I would try steroids, and I would even consider thalidomide, although it's a real stretch. But I mean, Johan Skuman at Tigerberg obviously was the pediatric guru on that. And if it's a granulomatous process, then maybe some parallels. James, or anybody, any last comment, and Hafsah?
Mark, thanks. I mean, yeah, it's a reasonable suggestion. My understanding is that you sort of earn your thalidomide if you're on steroids and not responding, and you need a sort of further, you know, TNF blockade or immune modulation. I mean, I suppose ideally this child should have intracranial pressure monitoring and see. It's been used mostly by the Tigerberg group for tuberculous abscesses, you know, and I think these may be evolving abscesses. And Hafsah and the neurosurgeons looked at a few case reports where surgical excision, which is actually mentioned in some of the guidelines, comes into this because of the, you know, the relative lack of efficacy of all these drugs. So maybe we do need to look at treating the intracranial pressure if that's driving some of the deterioration. I mean, I think just a comment. I sort of feel like we got a bit caught off guard that this looked and felt like Balamuthia. We took a while to get confirmation of that, but we thought we had a bit more time given the walk-in presentation between that and a CNS deterioration. But, you know, it actually started quite quickly, and one wonders whether we started empirical therapy earlier, whether that would have changed or not. I'm really not sure about that. Yeah. But, you know, just thanks to everybody. This was an extraordinary team effort. Miltefosine costs probably 50,000 Rand a month from our pharmacy contacting the company, and yet WHO gave us 2 months free supply. We haven't crossed the ethical boundary of donations, which ended 2 months yet, but we thought, let's go for it, and everybody pulled together, including the couriers who helped enormously. So thanks very much to everyone.
Amazing. No, thanks very much, and a really fascinating case. Hafsah, beautifully presented, and thank you to everybody who's participated in this discussion.